Sunshine. Woo! I'm back. What up, everybody? It's Tommy Sunshine. And I'm back, baby. That's right. I got me a little eggnog with, Captain in there. And today's reaction is going to be a little different than normal. It's going to be a little different than normal because what today's reaction is going to be about is about a total hip replacement surgery in my hip. That's right. Here's the before picture. There's the before picture. Oh. And there's the after picture. Oh. Right there. Look at that. That's my new hip. Looks good, don't it? Yeah. So anyway, that's what today's reaction is going to be about. It's going to be a little long-winded as well. I'm going to warn you ahead of time because the video I'm going to watch a video which takes you through a total hip replacement. It's not my video because my doctor was a little leery about taking a video of me getting my hip replaced. But it's going to be a pretty involved video that's like 18 minutes long. So that right there is going to tell you it's going to be longer than normal. But I wanted to tell you also, just give you a little bit of heads up in case you're going into this type of surgery as to what you may expect. What I had to suffer through, or saying suffer through isn't a good word, but I guess it kind of is because I've been suffering through this shit for the last year and a half. My hip started hurting like June of last year, not this year, last year, and it's been killing me. And like around February of this year, it really started really hurting really bad. And so I have arthritis in there. I don't know if it's rheumatoid or osteoarthritis, whatever it may be, but had to get it done. And but before we get into all of that, let's just give you a good shout out and thank you. Do my shout outs and thank yous. First off, thank you for all you guys. We got 13,100 and something subs now. Makes me feel so good. Imagine now that my hip doesn't hurt so bad anymore, we'll be doing a lot more, having a lot more activity. People might wonder, why would a bum hip affect the amount of production work that you do with YouTube? And, really, the only answer I have for that is it's not very difficult to sit here on my ass and do a video. But one thing that is difficult is like getting the motivation to do anything creative when all you can think about is this sore pain in your hip that you can barely friggin' move around with. That sucks. And now that I don't have to worry about that, hopefully, unless I'm just really lazy, which, come on, we're not gonna go there. But anyway, shout outs. Look, I want to give a shout out to everyone at Burlington County, what is it? Obstetrics or whatever. I can't even say the damn word. But specifically, I want to give my doctor, Dr. Koa Nguyen, a big shout out. You fixed it, doc. You did it, man. Look, this guy, he's so cool. At the beginning, he's like, well, you need to lose some weight, man. You really got to lose some weight if you really want this thing to last. And then I went back a month or two later and I had gained a little weight. He's like, you know what? I ain't doing this unless you lose 30 pounds, get down under 300, and then I'll do it. So he got me started losing weight too. I've lost 35 pounds already. He told me to lose 27, and I've lost, 37 pounds so far. I'm down to 290. I started at 327. So thank you, Dr. Nguyen. Awesome job, and I appreciate you pushing me to get it done. And and I feel better. Like the moment the surgery was done, I almost felt better. I mean, it was a different kind of pain because I had just been hacked open. Well, I shouldn't say hacked. You goddamn surgeon. You didn't hack it open. You're like, finally sliced and diced to the hip bone of the Sunshine Man. But, so, yeah. So that's Dr. Wen. Sam Lasowski, she was like the coordinator, but she like helped me out for like getting all my appointments set up and like pushing me to like, if I forgot to do something, she'd call me up and let me know. And she also got me all this video, extra information. And anytime I asked like Dr. Wen, I was like, hey, I do YouTube. Can I get a video? She took care of that for me. So Sam Lasowski. And then I got to give a shout out to Danette and Ellen, the RNs that were in the hospital for me that day. Guys rocked, kept me comfortable, kept me like, you calm my fears that I may have had. Ellen and Danette, appreciate it. And finally, my PT guru, Stephanie, thank you, lady. I appreciate it. She gave me all the exercises to do, and she made me do them. And apparently, she was very pleased with my progress. She got me out of PT early because I did all my exercises. So, do your exercises if you get your damn hip replaced. What else? So, the timeline. So, we're going to start out, this is what we're going to do. We're going to start out 2 weeks before the surgery, and we're going to go all the way through the surgery and go 2 weeks after the surgery. So 2 weeks before the surgery, I had to quit taking my meds that would like interfere with the anesthesiologist's medication. So he told me to quit taking like fish oil, vitamin E, and my multivitamins because, I guess it would thin your blood or thicken your blood. One or the other. I'm not sure which, but it did one or the other. So you just quit taking that. That was no big deal. But around that time, I got like real freaked out, and I called up or I sent Sam a message. It's like, God dang it, I can't believe this. This guy's going to basically cut my leg off and I'm freaking out. And I did it one night when I was drinking. I sent her the email, and then the next day she wrote me back, said, "Don't worry about it. It's no big deal." And I was like, "Oh, I'm sorry. I was just freaking out, But then that day, Dr. Wen called me up, and he just totally put me at ease. Said, this is a very precise thing. We're using a robot. Like, this is Makoplasty surgery that uses a robot to actually make sure the cuts are precise. And the joint is formed correctly or something. I don't know the ins and outs. We're about to learn it, okay? So, but I was really impressed how when I freaked out, they called me up and they set my mind at ease and they really took individual care and thoughtful, just treatment of me. And I appreciated it. Made me feel special and put me at ease. What else we got? Morning of. Okay, so the morning of surgery, I only was to take two medicines. One was omeprazole, the heartburn medication, and the other one was amlodipine. It's a heart medication, high blood pressure medication. So I take two high blood pressure medications. They told me just take the one and take the other one, and then the other, like I also take like atorvastatin, which is like a cholesterol medication, and I take another one, but nothing. Just take the two meds, and the anesthesiologist would take the rest, right? Or he would take care of everything else. He would control your heart and your blood pressure while you were getting cut on. So that was the morning of medications, and they said to take a shower, Take a shower, but don't use any deodorant because they don't want nothing on you, nothing nastiness. So I took a nice shower, got ready. And then the morning of, I arrived, and Danette came up to me, and she had a packet of like 7 warmed up wet naps. And they were medical wet wipes. They were thicker and had some type of medical chemical on them to make it kill all the germs. And she gave me a little picture chart of like, your underarms and your chest and your head. And she gave me like 7 or 8 of them and said, clean all those parts of your body again, wipe your ass, do as good as you can, she said. We'll take care of that. But I was able to wipe my ass pretty well. So I cleaned all. I was like, well, I took a shower. She's like, it don't matter. We don't trust that shit. You got prove just wash it. Just wash your old nasty body. Come on. So I did that. That was the morning of. And then the anesthesiologist came by, like, after a little while, and he was going to give me, I can't remember what he called it, but it was like a leg block or something. It was like a lumbar poke that at the bottom of my spine that would just kill the legs. But he wasn't hitting it, man, and it was like, I could feel that needle going in there and poking on the freaking spinal cord, and it was like, and he's like, don't jump, it'll fuck you up, and I was like freaking out, and but finally they're like, arch your back and hold it, and they finally got it, and it was my leg started to die, and that's pretty much almost like the last thing I remember, because they did that, and they started wheeling me out soon after that. Oh, but another thing that was kind of cool about like the prep work, I guess that's the prep, that Danette. And then Ellen came in and helped Danette. They gave me a few more meds. I think they were pain meds. I'm not sure for the spinal tap or whatever you call that damn thing. But that was not my favorite part. I don't know how they're like, don't jump and all this stuff, but I don't know how they can tell you not to jump when they're sticking a goddamn needle this motherfucker long in your goddamn spinal cord, and you feel that shit going in. It's like, woo! It's like, F that, But yeah, so that was that. I was the anesthesiologist. Then Dr. Wynn came in like after. Maybe it was during that, but he came in and he like initialed the leg and pointed up, for the hip, I was a little nervous because he initialed it like underneath my knee, and I was like, he knows it's a hip, right? But apparently he did. Another thing about that. Oh, I just thought of something while I was talking, but I forgot already. But, what was it? It was something about, like, when I was getting ready, then Dr. Wayne came in and did, I don't know, maybe it'll come to me later. I can't remember, but I know around that time it was very busy. They were, like, doing all this stuff to me, get me ready for surgery. Oh, that's what it was. So one of the things is, like, what leg is it? You always hear the rumors about all the people that got the wrong leg amputated or whatever. Well, from the very first, even when I checked in, she put the wrist strap on me, She said, what leg's getting operated on? She asked me personally. I was like, my right leg. This one. And she's like, okay, so this goes on the opposite leg. So everything they stuck on me, they tried to stick it on the opposite leg. Like my IV came in on this side, on the opposite arm. IV came in on this side, They put the blood pressure monitor on this side but I guess it was a hard fit over here, so they wind up putting that over there. But anyway, so that was kind of interesting, I thought. But whatever. So that's about the last thing I remember is getting my legs deadened up, and then I went into surgery. And so that's what we're gonna do now is we're gonna go ahead and turn the TV on, right? And we're going to check out this total hip replacement surgery video. And I may fast forward.
Replacement surgery has been
I may fast forward through some boring shit.
Of the 20th century. It has changed many millions of patients' lives.
Like this.
Very mobile, ball in the socket.
And it's a...
So this is the actual hip replacement that I received. I believe that's exact. I mean, if you saw that before and after picture, like I was showing you earlier, you can see in the video like exactly what I got.
British success story. The original surgeons, engineers, and manufacturing companies were based in the United Kingdom, and it's something we can be rightly proud of.
Yeah, whatever.
What patients want is a pain-free hip that functions well. Hip replacement surgery is very successful in relieving pain. I think patients notice the day after surgery that the pain they had has gone.
Yeah, I have to say that the pain that I did have was gone the day after surgery, but there was definitely associated pains still with me. You know, that was huge. Well, it wasn't that bad. Like, they told me that I would like swell up and stuff, but I didn't really swell up hardly at all. But I had like really deep purple bruising along where the scar was. The scar's like that big, and there's two scars. One is like that big. I guess that's where they did the hip and put the joint in, and then there's like a small scar like about this long that I think that's where they stuck the robot arm in or whatever. I don't really know.
Same job as the hip. So we're very happy for people to cycle, to swim, play tennis, the sort of normal day-to-day activities they enjoyed in the past.
I'm looking forward to that. Oh, I don't like the look of that leg the guy's like wheeling around there, though.
It's the sort of normal day-to-day activities they enjoyed in the past.
Look like a piece of meat. Gross.
So hip replacement surgery for over 90% of patients is for arthritis. There are other conditions that patients may have and present with, but by far the majority are arthritis. Over time, the hip becomes damaged, the bones develop extra bone on them that make them stiff, the soft tissues become thickened and contracted, and that causes stiffness. So the patient may have difficulty reaching their foot to put socks on, tie shoelaces, difficulty throwing their leg over a stile when out walking or getting onto a bicycle.
Yeah. Oh, bicycle. Oh, yeah. I was riding my bike with my dog up until probably about a month before surgery, but it hurt so bad to like, kick my leg over to get on the bike. And I haven't gone bike riding yet, but I'm so looking forward to that again. I had to stop after a while because it just hurt too much.
So we're scrubbing up now to reduce the bacteria on our skin. Infections are great concern for any joint replacement. We're in a special theatre where there's a high flow ventilation system which reduces the bacteria in theatre to negligible levels.
The hip is a ball and socket joint. The socket is on the pelvis, the ball is on the thigh bone that allows movement in all directions, an amazing range of movement. As the hip becomes arthritic and the joint is damaged, the range of movement reduces. The bit that is damaged in arthritis is the ball and socket joint.
Yeah.
The hip replacement replaces the ball of the joint, and the thigh bone itself has actually got a canal in the middle. And that allows us to place the stem into the thigh bone.
So, I mean, did he like drill that shit out? Did he waller that shit out with like a drill?
Label up, please. The hip joint in most patients is fairly deep, and it's got important blood vessels.
Oh no, that's the booty. That's what they call that there. That right there is called the booty. Cause I got like on my booty, you can see. Right there. I would show you guys, but I probably get kicked off YouTube, and I don't know if I got that much nuts. Yeah, I'll show you my damn scar. Oh, God damn it, I'll show you the fucking scar. Let's look at it. Hey, this is a warning. This is a warning. There's the little scar. Right there. And there's the big scar. Right there. So hopefully I don't get kicked off YouTube for that shit. That's instructional television. But there's the booty.
Vessels and nerves at the front. It's got an important nerve at the back. I use a posterior approach to the hip, so the patient is lying on their side.
I just hate how it just looks like a slab of meat, you know? It's like this guy, you know, you're like, you can't feel nothing. It's just like, he's just like pushing it around and poking it.
And it's called posterior because the access to the hip
Ooh.
is behind the thigh bone.
Oh!
Diathermy to help stop the bleeding as we go. Just stopping all the little blood vessels underneath the skin that ooze afterwards if we don't do something about them now. So it's time well spent.
Because the hip is a deep joint, there aren't any real approaches that
Oh, God, I don't know if I can.
that allow you to just separate the muscles. Every operation, all the approaches release
This is the.
some of the muscles. The posterior approach that I prefer releases none of the muscles that take part in walking.
Oh, God.
Now the retractors. To position the retractors carefully, not capture the nerve at the back of the hip. This is
No.
the top of the hip joint. Just releasing the superficial layers.
Now I know why that hurt so bad.
Know where the nerve is. We just feel where the nerve is. It's down there. Homan, please. So I'm just identifying the piriformis tendon, which is the top end of my incision. We're going to protect the sciatic nerve which lies behind. So the nerve runs along here. I'm going to release this by moving the legs. I'm approaching the hip joint from the back, so I'm releasing some muscle off the back of the femur here, off the bone, so it comes off as like a sheet of muscle. You can leave the muscle on, but as you move the hip around during the operation, it usually comes off, so you might as well.
Dr. Wynn, man. Oh, my God. I can't. I don't know if I'm going to make it through this, guys.
Take it off carefully at the beginning
This might as well be my hip. It's not Dr. Wynn, though, so I know it ain't my hip.
of the procedure. So one thing I use, which is not particularly common, is a pin to measure leg length. So this pin goes above the hip, and I'm putting that horizontally across the hip. So
I knew.
there's two things. One, that acts as a retractor, and two, it acts as a leg length measuring device. So I'm
Look
going
at
to
him.
measure 7 centimetres.
Very important in all patients to optimize leg length. Then the hip will feel more natural to the patient, it'll move more freely, and there's less chance of it.
So one thing that I had to do, which I didn't mention like on 2 weeks prior, was I had to take a. Let's turn that TV off for a second. Whew, goddamn. Whew. So one thing that I had to do was get a CAT scan, and that was so they could get a 3D image of it to where they could get the perfect, get the robot perfectly lined up. So let's go.
Coming out of joint.
She was short by several millimetres before we started. So I'm now going to dislocate the hip. This is the femoral head. Now I'm just going to check that my pre-operative digital templating was accurate.
One of the essential parts of the planning prior to surgery is templating. All patients come in different shapes and sizes, as do their hips. So we have a software program that allows us to choose implant sizes. It helps us identify those patients that might be more complex, and it gives us a better opportunity to end up with a hip with all the muscles are at the right length and the hip feels more natural to the patient. I have a choice on this system of every single company's implants. We have in this hospital 6 different hip systems, and so I try and find the right system for this individual patient. I've decided she's an active lady, she's got good quality bone, so the computer automatically gives me a best guess. Now that is too small for that patient, so I can increase the size of the implant. It's that size stem. I'm trying to put it in the place that nature had the normal hip. So in this patient, that reproduces the hip anatomy. But before I do any cuts, once the hip is exposed, I can place a trial against the patient's natural bone to see whether my planning on the computer is actually going to be right for that patient. So the
Oh,
middle of
man.
the hip is there. This is the implant that I thought fitted, and that looks right too. I can see the Leicester canter. I can reference that. So on the x-ray that was 15 millimeters, 1.5. Then I divide the neck on the thigh bone, which allows the ball to come away. So the ball and the upper part of the neck is discarded. So this saw is going from the bottom to the top.
Oh.
So that is the femoral head. And the femoral head should be covered with cartilage. So you can see in this lady, that's solid, like ivory.
That's like mine.
And that's where it's worn away. That's the arthritis.
No cartilage. That's the pain.
I now need to approach the socket, the acetabulum. So the next part of the operation is to release enough soft tissues just to be able to move the thigh bone out of the way so we have direct access to the socket. So Hannah's holding the femur away so the soft tissues are tight. This retractor helps me release the soft tissues safely.
To get to
So
the...
I'm just going to remove some of the soft tissues. Anterior retractor, please. So the socket, from my point of view, is looking like this. What I need to do is put a retractor over the front so that I can see. So that goes over the front. This is quite a wide retractor.
Oh.
Hannah's going to hold that for a minute. I'm just going to release it a bit. What we're going to do. MIS.
See, this
That's over the front.
is what makes it
Now
hurt.
I'm going to release at the bottom of the joint. Another retractor.
I don't think
So
this
that
is the
one's
same
gone
type
in
of
about
surgery
6
I
o'clock,
had,
the
though,
other
because
one's
he
gone in
doesn't
about
have the
2 o'clock.
robot. Well, I don't know. We'll
I'll
see
use
what
the
happens.
Pin at the back as a retractor. The chain gets in the way, so we just put that under there, and then a retractor. Thanks, Hannah.
Oh, Jesus
So
fucking
I'm
Christ.
just going to remove the soft tissue so I know where the normal
I'm sorry about
socket
that,
is.
guys. So he's just cleaning out the ball joint.
So what I'm looking for is the rim, the edge, the bony rim. I want
Yeah,
no
he's just
soft tissue in the way.
Getting all...
So I
oh,
can see
yeah. Just cleaned it out.
all the way around the acetabulum from the front to the back and at the bottom without anything in the way. And then we prepare the damaged socket with hemispherical reamers that start small and increase in 2 millimeter increments. So this is a reamer, and it's basically got holes on it and
Reamer.
a cutting edge. So basically this
It's
goes
like a
in
bone
to
grater.
the acetabulum.
They're grating the bone.
Prepares the surface. If we make it too small, then the implant will be loose. If we make it too big, then we're going to be damaging natural bone. So we're going to start off, this is 46.
It doesn't look so
The first one
grindy as I thought it was.
Because it may be soft, this one's quite firm.
Ooh.
That's the first one. So we want to ream away the damaged cartilage, but not the bone. This one. So that's what we planned. That looks all right. So you've taken away the articular cartilage, which is the bit that wears away,
Yeah.
and then
just into the bone, so what we call the subchondral bone, just below the cartilage. You don't want to go too far, the bone then gets very soft, and also then the cup is too far in. So it has to be sitting in the right place. So this is the cup. So you can see on the outer surface is roughened to grip the bone. Twist it round to get the soft tissue out of the way. Alignment jig.
What the f... Oh! I just...
McDonald, please. Again, making sure there's no soft tissue in the way.
How does he set, like, does he have to put a pin in there to keep it from falling out? Or does it just...
So I can see that the implant is seated fully. It's aligned nicely. We're now going to seal the hole in the bottom.
Oh, he does.
And then in this patient, we're going to have a plastic liner. So this is plastic.
I don't know what type
And then
of
we need
liner.
to join the two together. So we implant it.
Once the socket has been implanted, we turn our attention to the thigh bone. And the middle of the femur is a canal, so that's where our implant's going to go. And that either is going to be cemented in, or it is going to be using uncemented implants. If we take these two stems as examples, this stem is for cementing. So you'll see that it is shiny and smooth.
The cement is going to all the little holes in the bone. The stem is in the middle of the cement mantle. It's not touching the bone anywhere, so we've got a complete cement mantle.
This is a cementless stem.
How does he...
This has got a roughened surface that helps bond the implant to the bone. Modern cemented and modern uncemented implants function just as well.
These come in sequential sizes and they impact the bone. So the soft bone in the middle gets impacted.
If we're using an uncemented stem, then we pair that increasing in size until it's stable.
That's 0. We thought it was 1. Right.
Oh, man.
This is the 32mm trial head. So we have the real cup in, but only a trial head. Yep. Yep. So first things first, the tension. So if it's about the right, you should be able to extend the leg and flex the knee without it being too tight. So if she's lying in bed at night, that is fine. If she's sitting in the chair, that's fine too.
Oh.
So if it was too long, I'd take the stem out and I would put in the smaller stem.
So
If
on
it's too
mine, they
short,
used
I
a
can put in bigger
robot to
stem.
do all to make sure it was in totally aligned. And
So
I
once we've prepared it,
guess
we
this.
can put the real component in. So there's our stem. Uncemented, it's got a rough surface, it's got a coating that helps it bond onto the bone. It's exactly the same shape as the brooch
So
before.
I guess
so
what
I have
this-
to line it up, putting it in the same direction. And you hear the sound change as it gets
Yeah.
fixation. We're going to trial it now. Whether we think it's going to be this one, we will just trial that again. This is the shortened version. So we still have an ability to change things a bit at this stage with regard to leg length.
Once both the socket and the stem are in place.
See, mine was like due to
reduce the
leg
hip,
length, I
you're
think.
happy with your leg length. At that stage, you still have an option to change things. The femoral head, the ball of the joint, comes in various lengths. So you have an option, even after your socket and your stem are in, to optimise.
So in bed, she's all right. Sitting in the chair, she's all right. She can cross her legs, she's all right. So ideally what you want is equal leg length and a stable hip. And if you get your leg length and offset right, then the muscles around the hip will be at their correct length. The hip will feel more natural, function better,
Okay.
and return to a higher level of function.
All
My
right.
options now at this stage, I can have a metal head, I can have a ceramic head, which has better wear of the plastic. The downside of ceramic, even though it's very rare, ceramic's brittle and can fracture. So this material is called oxinium, so it's actually a metal ball, and the surface has been treated to become ceramic. So you
Oh,
have
that's
the
what I
benefit
get.
of ceramic without the downside of fracture. So you can now see this lady's new hip.
Ooh.
So that's that.
Hip replacement surgery is the most effective operation in medicine for relieving pain, increasing the range of movement, and return to function.
Okay.
And when they come back for review at 6 weeks, most patients are comfortable, walking independently, and are very happy with their progress. And quite soon, within a matter of a few months, be back to the activities that they want. And I think that is why I decided to pursue a career in hip surgery.
Okay. All right, so that wasn't exactly the hip replacement that I got because I had, like I said, I had the little robotic arm that went in there to make sure it was all good. But that was pretty much what all he did, I imagine. But holy crap. So that was hard for me to watch. But look, amazing that it worked and it worked out so well. So after that, when I woke up from the hip surgery, the first thing I noticed is that I had a terrible sore throat. Apparently, I was moving around a little bit. My legs were moving around, so that spinal tap that hurt so friggin' bad, I didn't need it because I had to do general anesthesia anyway and stick the tube down my throat. And when I woke up, I could barely talk. I was hoarse, and I had a sore throat for a couple of days. But yeah, so that was that. What else? Recovery. Other than that, recovery. They gave me like some stool softeners because they gave me like gabapentin and what's the other one? Hydrocodone acetaminophen for pain relief, and that constipates you. So they give you a stool softener, and I didn't take a crap for like 5 days almost. 3 days I squeezed a little turd out, but then it was 5 days before I was like regular, and that was like I only took my pain meds for 5 days. They gave me 2 weeks worth, and I did my PT sessions. I had like 4 or 5 PT sessions, but they all went well. Other than that, man, once again, shout out to Dr. Wynn, man, Sam Lasowski, and my nurses, Danette and Ellen, man. You guys rock. Stephanie, my PT therapist, man, thank you so much for helping me. I feel much better already. It's been 2 weeks and a day. It's been 2 weeks and 2 days. Yesterday was my 2-week appointment. He cleared me to do anything. Like, I was using my cane still. He's like, why are you using that thing, man? You don't need that. And so I quit using the cane. But that did, I went to Walmart yesterday, and I did get a little soreness and tenderness. And even now, like, if I get up right now, it's a little sore at first. It like needs to warm up a little bit. But yeah, shout out to Dr. Wynn. Burlington County Orthopedics, man, you guys rock. Thanks for the new hip, and I'm sure I'll pay for it. And until next time, peace out, motherfuckers. My name's Thomas Sunshine. I'll see you.